So I'd like to introduce Dr. Rina S. Fox. She's an assistant professor at the University of Arizona. I almost gave you my university. University of Arizona College of Nursing, as well as a member of the Cancer Prevention and Control Program and the co-director of the Behavioral Measurement and Interventions Shared Resource at the University of Arizona Cancer Center. As a licensed clinical psychologist, her research focuses on understanding how psychosocial processes impact cancer survivorship and she also develops behavioral interventions to decrease symptom burden and improve health-related quality of life. Currently, she is leading projects focused on 1, understanding and improving sleep health in cancer, 2, addressing the unique psychosocial needs of adolescent and young adult cancer survivors, Dr. Fox received a PhD in clinical psychology from the San Diego State University, University of California, San Diego Joint Doctoral Program in Clinical Psychology, and completed a postdoctoral fellowship in cancer prevention and control at the Northwestern University Feinberg School of Medicine. And thank you for being here, Dr. Fox.
Absolutely. Thank you for having me. I'm going to pull up my slides. I must say, I always get a little tickle out of hearing the name of my graduate program because it is probably the longest graduate program name in the history of grad school. So I always enjoy hearing that. So again, thank you so much for having me here today. Today, I'm going to be talking about coping with sleep disturbance in the context of cancer. So let's talk a little bit about sleep. Sleep is one of those things that, with a number of other aspects of health and well-being has really been put into the spotlight over the past, decade, give or take. And if you think about our days, right? If most people spend about 8 hours at work and about 8 hours doing other things and about 8 hours sleeping, we are spending 1/3 of our lives asleep. So this really suggests, as was stated in this Science article a couple years back, that sleep is a non-negotiable biological state. It is required for the maintenance of human life, and our need for sleep parallels that for air, food, and water. I heard somebody once say, and I thought this was so brilliant, that if we really are spending 1/3 of our lives asleep, if it is not actually a biological necessity, that is one of the biggest evolutionary mistakes that our species has experienced. So, seeing as that's typically not how evolution works, it probably is that imperative. When we think about sleep disorders, there are 5 main types of sleep disorders that are in the diagnostic manuals used by providers. Those include insomnia, which is what most people think of when they think of difficulty sleeping. There are, of course, specific criteria. I'm actually going to speak about those in just a minute. But with insomnia, it's what you usually think of, or insomnia-like symptoms. Other main categories include sleep apnea, or more broadly, sleep-related breathing disorders. Sleep apnea is when, due to either neurologic or physiologic reasons, your body will briefly stop breathing for periods of time during your sleep episodes, and your body will then wake up so you can have more access to oxygen. There's hypersomnia. It's kind of the inverse of insomnia. It's needing more sleep than is generally considered typical. Narcolepsy is an example of a hypersomnia. You also have circadian rhythm sleep-wake disorders. These are when it's not so much that your body can't sleep or your body isn't able to stay asleep, but that what your body actually wants for its sleep schedule, what your internal rhythm is telling you is the right thing for your body, doesn't match our societal schedule. So if you take that word circadian and you break it up, you get circa, which means about, and dia, which means a day. Circadian, it's about a day. It's our natural rhythm that repeats every one day, give, take. Parasomnias are, I was going to say a catch-all, but that feels wrong, but it's a kind of multidimensional compilation of sleep disorders. Broadly speaking, this is doing things more typically characterized as wake during sleep. So this includes things like sleepwalking, sleep talking, sleep eating. There's a disorder, called REM behavior disorder, where people physically move around and act out their dreams. There are also things, sorry, I saw the chat and it distracted me. But basically, anytime you're doing something that's typically characterized of awake, but during a sleep period. What I'm going to focus on today, there it is insomnia. Again, this is what most people think about. Insomnia involves difficulty falling asleep, difficulty staying asleep, and/or waking up too early. Again, for it to be categorized as an actual disorder, it does need to occur a certain number of days per week and last for a certain number of weeks to meet that criteria. But otherwise, these would be called insomnia-like symptoms. The other aspects that need to be met for it to be considered problematic are that it has to bother you. If it doesn't bother you, then it's not a disorder, and or it has to interfere with you living life the way that you want to live it. So this is what I'm going to mostly focus on today. One thing I get asked all the time is how much should I be sleeping anyway? And if you think back, 5, 10 years ago, there was a silver bullet answer. It was 8 hours. You needed 8 glasses of water a day. You needed to sleep 8 hours a night. And more recently, that has shifted. So there's no longer a one size fits all answer, but more of a range. So this is taken from the American Academy of Sleep Medicine. They now recommend for most adults age 18 plus that you want to be sleeping anywhere from about 7 to 9 hours per night. Some people need a little bit more, some people need a little bit less, but for most people, you're aiming for 7 to 9 hours per night. And you'll notice that earlier in life, during infancy, toddlerhood, that sleep need is greater. And as we progress through life, we do start needing less and less sleep. Again, you see this really as children develop, you see their need for sleep decrease. But from 18 plus, 7 to 9 tends to be pretty consistently what's recommended. So let's talk about sleep in the context of cancer. How common is sleep disturbance in cancer? When does it happen in the context of cancer? How long does it last after a cancer diagnosis? The short answers to these questions are that it's extremely common in the context of cancer. It really happens kind of across variables, across ages, sexes, genders, disease types, different treatments, and it can last for years following diagnosis and following treatment. And one thing that I think is of particular interest to this population is that there has been shown to be a heightened prevalence relative to other cancer types among those who have had a gynecologic cancer. These findings, these numbers here, are taken from a meta-analysis and systematic review that was published in 2022. So you all just heard Dr. Hawk talk about what a systematic review is. This is kind of the highest quality evidence that we get in scientific literature, where somebody will go out and they'll say, I want to find every single paper that's ever been published that meets a certain quality of rigor that has talked about people who have had cancer who also report difficulty sleeping. And overall, how many of them are actually reporting difficulty sleeping? So you can see at the bottom, there in the parentheses, there are those Ks. The K tells us how many studies these authors found that looked at that type of cancer. So there were 7 studies that specifically looked at people with a gynecologic malignancy. They did not look at any other cancer types in that study, and they found a prevalence of 63.6% of sleep disturbance. From this study, when they looked at absolutely everybody together, all of the studies combined, the point prevalence was 60.7%. So again, we're seeing a little bit higher in gyn. In terms of how long it lasts, this was a study, that was published in 2020. They looked at people who were 9 years post-diagnosis. This was something that was pretty significant because most studies look maybe 1 year into the future, sometimes even 5. 9 is unusual to get that type of longitudinal or over time evidence. So this was a study with about 1,900 people. Again, they were 9 years post-diagnosis. I will say, we see this a lot in the literature. I recognize I'm preaching to the choir that you get a lot of people say, oh, here are all the breast cancer patients we had. We also see here are all the prostate cancer patients we had. And then here's everybody else. So they didn't split it up into gynecologic malignancies, cervical cancers, any more fine-grained than that. But you can see we had 31% breast, 32% females who had a cancer that wasn't breast cancer. So take that as you will. But I do think we still see some pretty interesting information here. So you could see 9 years post-diagnosis, there was still 20%, so a fifth of people who responded to this survey who said that their sleep quality was poor. 50%, half of them were reporting high levels of sleep disturbance, and a little bit more than a quarter, 28%, were reporting regular usage of sleep medications. So it lasts for quite some time. Why does this happen in the context of cancer? The short answer is we don't really know. This is an ongoing area of investigation. There are theories and there is building evidence or accumulating evidence as to what might be happening. So some of the theories out there include the disease itself. Certain cancers may have aspects of the tumor microenvironment that contribute to sleep disturbance. There are also psychological factors that can contribute to sleep disturbance, increased anxiety, increased depression, increased fatigue. You see, pain is a big one. Pain can be disruptive to sleep. A lot of people will wake at night due to pain. Medications can be contributory. Things like stimulants or opiates can all contribute to sleep. And then the cancer treatments themselves can also contribute to sleep disturbance. One thing I didn't have on a prior slide, and I meant to, so I apologize for that, was that we generally see in people who have had a history of cancer relative to the general population, the rates of insomnia and insomnia-like symptoms are typically about 2 to 3 times as high. So we see that this is something, it's happening in the general population, of course, but we are seeing more of it among people who've had a personal history of cancer. In terms of the impact of sleep disturbance on somebody's overall life, it's been associated with things like reduced quality of life, increased depression, increased fatigue, increased anxiety, vasomotor and endocrine symptoms like hot flashes and night sweats. We see increased cognitive impairment, and there's some evidence linking to mortality as well. So anybody who's had a bad night of sleep or maybe a handful of bad nights of sleep knows that they're probably not their best self right on the tail end of that. And we have the evidence to support that as well. And one thing I always like to point out in these talks is that it's not just patients. So we see this among familial caregivers as well. I will see the rates of sleep disturbance tend to be higher among people who are receiving treatment for or who have completed treatment for cancer. Um, but we see it in caregivers as well. So if you look on the left side of this screen here, you can see those yellow bars are the patients, the blue bars are the caregivers. And you can see that they're looking at different measures of sleep disturbance. So that PSQI is a measure called the Pittsburgh Sleep Quality Index. It looks at a bunch of different aspects of sleep and sleep disturbance. And they had a cutoff score where they said, what percentage of our population is above this cutoff score that tells us, hey, this is significant poor sleep that we want to pay attention to? What percent of the population was below that cutoff score and what we would consider subclinical or likely subclinical symptoms? And you can see about 50% of patients and maybe 45% of caregivers were in that something's going on here category. We saw very similar things with the general sleep disturbance scale. That's what the GSDS is. And then TST stands for total sleep time. And they used a cutoff of 7 hours. So what percent of their sample was sleeping less than 7 hours on average per night? That one, we didn't see much of a difference at all between patients and caregivers. It may be that these are spousal caregivers who are bed sharing, and that could be part of it. That was not necessarily something, though, that was determined for certain, if I remember correctly. And I will say this was a mixed cancer sample as well. On the right side, you can see looking at specific components of that Pittsburgh Sleep Quality Index measure. So we saw this with sleep quality, sleep latency, which is the amount of time it takes between when you get into bed and say, hey, I'm ready for sleep now, and when you actually fall asleep. So that sleep onset period. You saw this for sleep duration, sleep efficiency, which is a ratio measure. It's the ratio of the amount of time you are spending asleep relative to the amount of time you're spending in your bed. So if you get into bed at 8 o'clock p.m. and you stay in bed until 7 o'clock a.m., but you're only actually asleep for maybe 6 or 7 of those hours, that efficiency percentage is going to be pretty low because the ratio of time asleep to time in bed is going to be pretty disparate. Whereas if you get into bed at 11 and you wake up, get out of bed at 7, but you're asleep from 11:30 to 6:45, that sleep efficiency is going to be a lot higher. You see this for sleep disturbance, sleep medication usage, and daytime impairment as well. So that was a very, quick and dirty overview of what we know about sleep in the context of cancer. I am mindful of the time, and I want to shift gears now to what can we do about it. So this is a publication that the National Comprehensive Cancer Network puts out. They just re-released new guidelines in 2024. These are patient-facing guidelines. You can share this with the people who are part of your chapters. You can reference this yourself. You all may already know about it. I wouldn't be surprised if you did. But this has information about survivorship care for cancer-related late and long-term effects. I'm only going to talk about a couple of the things in here, but if you flip forward to, I think it was section 16 is the section on sleep, they talk about a number of different strategies for improving sleep disturbance in the context of cancer survivorship. One of them is sleep hygiene. We're going to go into that in a little bit more detail in a bit. Another is medication. I have literally one slide on this. Medication is not my specialty. I am not trained in pharmacology, so we're not going to go into it very deeply, but I do like to acknowledge it because it's a very common strategy that's used. And the next is cognitive behavioral therapy for insomnia, which is where I'm going to spend a little bit more time. So first thing I want to talk about is sleep hygiene. A lot of people, when they look to go engage in behavioral intervention for sleep, engage in sleep hygiene practices. You might get a handout from your doctor saying, here are things you can do to sleep better. These include things like avoiding alcohol before bedtime, not watching your television in the bedroom or using your phone right before you go to sleep, not eating or drinking anything that's too heavy that's right before bedtime, having a dark, calm, quiet, cool, relaxing sleep environment. Trying to maintain consistency in your sleep schedule. So waking up and going to bed around the same time every day, not exercising too close to bed, not watching the clock. These are all behaviors that can be contraindicated for sleep. So this is basically taking all of the things that we as humans are tempted to do, that we often do, like reading or perhaps doom scrolling, if you will, in your bed right before you go to sleep, that don't really set us up for success with sleep. However, I think of sleep hygiene the way I think of dental hygiene. So, dental hygiene is a critical part of oral health, right? You want to floss, you want to brush your teeth every single day to minimize the likelihood that you have gum disease, that you get a cavity. But dental hygiene is not going to solve everything. Once you have a cavity, you can brush and floss to your heart's content. It's probably not going to fix the problem. You can't brush your way out of braces, for example. So while this is an important aspect of increasing the likelihood that you maintain sleep health and decreasing the likelihood that you develop something like an insomnia disorder, it in and of itself is probably not the right tool if you already have or somebody who you're working with already is experiencing insomnia. I'm going to touch on sleep aids very briefly. As I said, the number one thing is that they are the most the most frequently prescribed psychotropic prescriptions, particularly for people who have a history of cancer. The evidence behind them, however, is pretty mixed. A lot of the evidence does come from the general population, but even with that, we see I actually listened to a lecture this morning and they talked about trazodone as one example. Trazodone has been shown to increase sleep time by 0 minutes. It has been shown to decrease how long it takes to fall asleep by 0 minutes. It has been shown to change the length of time you spend awake in the middle of the night by 0 minutes. There is some perceived benefit on sleep, and I think there was a perception or an impact. I honestly can't remember, and I don't want to misquote this, but it did seem to have some impact perhaps on the number of awakenings that occurred, or at least the perception of the number of awakenings occurring. But it didn't have as strong of an evidence base as you might imagine, given how frequently it is prescribed for sleep. So this is something that I think is not super well known and probably needs to be better studied. But again, that is outside of my area of expertise. What I am able to talk about a little bit more is something called cognitive behavioral therapy for insomnia, or CBTI. This is the gold standard treatment for insomnia disorder. It involves things like changing your sleep schedule, changing what you do when you're not able to sleep at night, addressing your thoughts about sleep. It includes education about sleep, sleep hygiene, what we just talked about a couple of slides ago. It's an important part of this because you don't want to be engaging in behaviors that might get in the way of sleep. But again, it in and of itself, sleep hygiene by itself is not enough. It also can incorporate relaxation strategies, particularly if physiologic arousal is a large component of sleep disruption. And for somebody who's maybe taking a medication for sleep and wants to discontinue it, it can incorporate a medication taper over time. In terms of what it looks like, if anybody is familiar with cognitive behavioral therapy for other considerations like depression or anxiety, the structure is pretty similar. The content is different, but the structure is very similar. Oftentimes, it involves once a week interactive sessions with a therapist or somebody who is specially trained in behavioral sleep intervention. It can sometimes be less frequent than weekly. And typically, it's pretty quick. Typically, it involves only 4 to 8 sessions or modules. The way I like to think about this is that medications work faster, CBT works longer. In terms of strategies for finding a sleep medicine provider that can be shared again with your chapter members or with others, there are a couple of kind of repositories online where providers can be found. There's a Society of Behavioral Sleep Medicine that has a list of its members. There's also an international directory of CBTI providers that can be accessed. And for those who either aren't able to interact with a therapist weekly due to insurance reasons, or just the structure of their lives doesn't really enable that, there are online programs and apps available as well. I will say the evidence for those is a little bit weaker. It seems that they do work for some people, they just seem to work for not as many people. And a lot of times they are automated, so you're not interacting with another human being on the other side. The last thing I want to talk about quickly is there's also opportunity to participate in research. So the way that I originally was introduced to NCCC is through some of the research that I'm currently leading, focusing on sleep in post-treatment survivors of gynecologic cancers. But for people who are interested in research in general, whether it's about sleep or not, there are a couple of different ways to find research studies that are ongoing. So one resource is clinicaltrials.gov. This will have information about studies that are being conducted nationwide and even worldwide. It's a searchable registry that tells you the purpose of the study, who can participate, where the study is happening, the contact info for the people who are in charge of the study. I will say, just so you're aware, not all trials have been federally evaluated that are part of this registry, so that is something to keep in mind, but it is a really good place to learn about research opportunities. Another, if you're looking specifically for NIH trials, is a searchable registry of clinical studies that are taking place at the NIH Clinical Center in Bethesda. And then another resource is something called researchmatch.org. This is an NIH-funded initiative, and it's a free national registry of research volunteers. And as a scientist, I would be remiss if I didn't share my study with you. This is a study that's currently ongoing. We are actually going to keep it open only for about another month, and then I think we're going to close recruitment. This is the final opportunity to share with your chapter members. This is a study that is trying to figure out what are the best ways that people who've had a gynecologic cancer can change their behaviors to hopefully get better sleep at night, excuse me. So there's a QR code that can be shared there to fill out an interest form, just providing contact information. And then somebody from the team will reach out if anybody is interested in learning more about one particular ongoing study. So I know time is tight today. I'm going to wrap it up there, but thank you so much for having me and listening to me talk a little bit about sleep.
Thank you so much, Rina. I definitely would like to get that information on your study and share it with our community at large. And also, I want to make sure that we have those NCCN guidelines that you shared on our website. Also, a really
Yes,
great resource
absolutely. And the link to those guidelines are also included on the slide.
on the slide. Yeah. Okay, thank you. I'd like to open the floor for questions. I see one in the chat right away from Jolene. Do you want to ask her, Jolene, or do you want me to read it out?
No, I'll ask her.
Okay.
So hello,
Hi.
interesting presentation. So I wanted to say that not only am I a cervical cancer survivor since 2006, but I recently was diagnosed with breast cancer this past June. I had 2 surgeries, and my last radiation treatment was about the middle of January. And when I was diagnosed, after one of the surgeries, they put me on trazodone. So I guess I'm asking you is based off of what you stated tonight, are you saying that trazodone has no benefit for me whatsoever? Because
Excellent question.
that's how I took it, to be honest with
Yeah.
you.
So I think you are in your body, right? And you know
Mhm.
what your experience is in a
Yeah.
way that nobody else ever is going to.
Yeah.
I think, and again, this is why I always give the caveat that pharmacology is not my area of
Sure.
expertise.
Sure.
In the studies that have been done, from what they've seen is overall, right? They're looking at mean values, they're looking at lots of different people. And I am not 100% positive, but I am almost certain the study that was cited to me this morning was not cancer specific. So it may be that there are cancer specific variables coming into play that would change things.
Okay.
Overall, when they look at a bunch of people, they see that it's not having significant impact on the things that most sleep researchers look at as their primary outcomes, like
Sure.
sleep duration. Again, that ratio of time in bed to time asleep, things like that. what I would say, if you are taking it and your doctor thinks it's great and you are happy,
Mhm.
cool, right? Like I would talk to your doctor and make sure that you're having empowered and educated conversations with them about your
Sure.
health in a way that is consistent with what you want for your
Mhm.
treatment, be it for cancer or for any other aspect of your
Mhm.
life. But again, this is why the generalizations are sometimes a little bit hard because they may or may not be the experience that you are having.
Mhm. Okay. I was just curious because now you've got me questioning whether or not I should be on trazodone. So I'll talk to my doctor when I see them next. So, now that one chart you had up where it had like the percentages, and it was like, I think it, you said, or I think it was like 33%, what was it? Like cervical cancer, was it? Or it wasn't specific? And then,
The mixed gynecologic cancers in terms of how
mhm.
common sleep disturbance is.
Yeah, so you had 33% for, I don't know, something. I don't know if it was like cervical, but then you had additional, you had breast cancer was 31 or something. No, it's a
Oh,
different
this one?
screen. That one, yeah. So does that mean, I'm just asking for myself while you're here. Does that mean I have 63%?
No, great question. So this
Okay.
is just telling us about the people who were in this study. So of
Oh,
those
okay.
1,903 people, 31% of them were people who'd had breast cancer.
Oh,
20% of them were people who had had prostate cancer. That's a great question, and I
oh,
did not
okay.
make that clear when I presented
Okay,
this
because I'm
slide.
thinking, wow, I'm in a mess of fun, aren't I?
No. This
Okay.
is just about the people who were in this particular study.
Okay. Okay. Thank you for your clarification. I appreciate it. Thank you.
Absolutely. Selena, I see a hand.
Yes, hi, and thank you for doing the work you're doing. I actually see a sleep doctor, and since a side effect of my treatment was a grand mal seizure, I'm one of the lucky recipients that suffers now a neurological side effect, central apnea. So I use a BiPAP, and I think it would be really interesting. You didn't focus on obviously sleep devices and that focus of this presentation today, but I think, to me, I'm going, okay, and what are the other reasons I don't sleep all that well? I think when it comes to cervical cancer, I think it's pretty easy, I think, for most women to say if you've had advanced cancers that, you're dealing with bowel and bladder issues as well. So somewhere I think there's like a fine line between not just the cancer, but the symptoms of the side effects or the treatments of cancer that provide us with residual challenges that we'll probably never get away from. So I just kind of a little bit of a share and a thank you for doing this work because it does impact us.
Absolutely. And thank you for sharing your experience. And I think I appreciate your point also about seeing a sleep specialist and seeing a BiPAP. And there are different types of sleep specialists out there as well. So there are MDs, for example, who may be pulmonologists or may, be neurologists or trained in other disciplines who specialize in things like sleep disordered breathing. There are also people like me who are psychologists who are not trained to do that work per se, but are trained to do more behavioral sleep intervention. And there's a place for both. So I think it can absolutely be a form of integrated care. And you're absolutely right. There are certain things, you cannot behavior your way out of needing to wake up in the night to use the restroom. Like there are certain things that are just not going to be the target. And also, I think that there are still aspects of the behavioral and cognitive work that can contribute to that because it can have an impact on how it feels when you do wake up due to things that maybe aren't as easily targeted. So that's why I'm a huge proponent of that aspect of coordinated care whenever it's possible.
And I appreciate you saying that because I do think those components are crucial. So thank you again.
Thank you.
Well, this has been another great
Oh, I have
evening.
my hand up.
You got one more? Oh, I see it now in the corner. Sorry, it's just the way.
I just wanted to say that, I'm so thankful that Dr. Fox came today because in my experience in healthcare, it's the interdisciplinary approach where we get the best outcomes for our patient-centered care. And we really don't always have that opportunity, or frequently, you know, we don't just come in with our cervix in a handbag to, you know, get our care, right? And so, you know, you go to the gynecologist, and then, you know, but something else is going on, and then you got to see somebody else, and then the communication coordination. But really, to have the disciplines outside of our traditional providers is really wonderful, and sleep is essential. So, Rina, thank you so much, Dr. Fox, for your presentation and the work that you're doing.
Thank you. I'm looking in the corner now. Jolene, I see your hand
Jolene,
again.
hi, yeah. Okay, I guess I'll lower my hand now. What are your thoughts on magnesium? Because I have a cousin that lives in Minnesota, and she's like, oh my gosh, I've been putting magnesium on my feet at night, and it helps. So then what did she do? Of course, I'm having sleep issues, so of course I order this magnesium stuff. I don't know if you can see it. But anyway, what are your thoughts on that?
So magnesium is something that has been getting a lot more like pop culture attention recently. There was something, I'm gonna mess up the name. I think it was like Sleepy Girl Cocktail. I was like,
I need one of
I feel
those.
like it was probably on TikTok, honestly, last year, which I am not a part of. I am
Yeah.
not the target population.
Yeah.
But I feel like that feels like what it was, right? And honestly, again, I was not part of it, but I think that magnesium was part of that.
Okay.
I will say right now, I am not very familiar with the literature on that, so I
Okay.
don't want to misspeak about anything.
Yeah.
I think though, anytime you are going to put anything into your body, right? A supplement, an over-the-counter, anything, I think it's always wise to touch base with your provider, just
Yeah.
because there are certain things that can interact in really sneaky ways that we would never anticipate.
Oh, I
So
didn't think of
always
that.
touch base with your doctor and just say, hey, my
Okay,
sister-in-law or the internet or somebody told me about this thing. I'm thinking of taking it. What do you
Yeah.
think?
Yeah,
And make
that's
sure
going
that
back in
no
the box.
concerns come up.
That's going back in the box, doctor. I'm only
Just
out 11 bucks.
check with
so
your
that's good.
doctor, see what they think.
Okay. Thank you. That's a good idea. I should. Thank you.
I want to say one thing about that. You know, pharmacists are so underutilized. They know
100%.
everything about. They go to school for a really long time.
Yeah,
And they are great resources.
that's a
too.
thought.
Yeah.
Yeah, that's good. Thank you.
That's a fantastic point. Absolutely.
Agreed. I agree with that. Okay, I don't see any hands. So thank you very much, Dr. Fox, for joining us. This was definitely a new topic for this group. It was awesome. Thank you.